gastrostomy was placed in 1876. And at the beginning, there were a lot of complications, primarily peritonitis, because technique was not perfected. By the mid 20th century, the surgical gastrostomy became a standard of care. Until in 1979, Ponsky and other developed the endoscopical placed gastrostomy back tube. A few years later, 2 years, there was a first image-guided, fluoroscopy-guided, or IR, radiology placed gastrostomy was performed, and the rest of the history. Oh, that's great. Why did that move? Oh, here we go. So in 2000, the data I have, 283,000 procedures were performed, and only 7% was performed by radiology. So we definitely have a huge way to grow and surpass gastroenterology. So it's still the major players. And surgeons, and by the way, when we mention surgeons, most of the time they do the same PEG tube as a gastroenterologist. Almost nobody does open surgical. There's some literature out there about laparoscopic placement, but whatever I understand from my surgeons, it's very rudimentary and performed only in a few hospitals. The main indication for placement of a gastrostomy tube are obvious. First, the obstruction of the upper GI tract and inability to eat. Dysphagia, aspiration risk, quite common indication. Nobody knows exactly if it's real indication. I think we place too many gastrostomy tubes for this indication that it's actually not real. And supplementary nutrition for cachectic patients on chemotherapy, radiation therapy, and patient with impaired nutrition. Decompression of the gastrointestinal tract is one of the indications. Obviously, there is some controversial indications, such as refusal to swallow without terminal illness, forced feeding, I guess, dementia. And here is a very interesting idea. There's a huge difference. It's pretty much related to some ethical issues. And when we wrote this document, there was a huge discrepancy between European literature and American literature. And when we wrote this document, I was not the one who was responsible for ethical issue part, but one of gastroenterologists. And if you read the follow-up articles of the guidelines, there was a very, very sharp and critical letter been sent to us. In the sense, it blame us for publishing this document, and where we said that there's a situation where you can stop treating them terminal illness, and blame us as being non-ethical. So one of my co-authors wrote the response. It's kind of an interesting topic, but maybe a little bit outside this talk. There are a few clinical contraindications, and one more time, we significantly different here than in Europe. Terminal disease with poor life expectancy. It's in Europe. It's an outward contraindication. In the United States, it depends where you are. Persistent vegetative state, the same thing. Anticipated short-term impairment of the intake under 4 to 6 weeks. So here you can actually feed the patient with an NG tube or oral tube. You don't have to do gastrostomy, and that's actually very common. This mistake is quite common, where you will ask to do gastrostomy, and when you look at their history, you realize that this patient actually needs gastrostomy for 2 to 3 weeks. 2 to 3 weeks is perfectly. A patient could be perfectly fed with NG tube. There are some absolute contraindications, such uncorrectable coagulopathy. And some unsatisfactory percutaneous access. That means there is something on your way to reach the stomach, for example, liver, or spleen, or large colon. I found that almost extraordinary. I don't remember the last case where we cannot find a window to get into the stomach. You always can do that. Oh, let's say almost always can do it. Sometimes you need to use a CT guide, but most of the time you can get the tube in the stomach. Obviously, acute abdomen and infection. There are few relative contraindications. Massive ascites, just small amount of ascites does not preclude you from placing gastrostomy tube. But if you drain this patient every week, 5-6 liters a week, I would say you have to consider placing the gastrostomy because this fluid can create a separation between the stomach wall and the abdominal wall. Abdominal viruses mentioned in the books as a relative contraindication. I never, not from my experience, I never seen bleeding from viruses. We pretty much go and place gastrostomy. Obviously, the enormous viruses on the arterial wall will consider it, but I don't remember one case we postponed gastrostomy or refused to do gastrostomy for the small viruses. Previous gastric surgery, relative indication. One more time, we use an ultrasound, CT, fluoroscopy. You always can get tube in even a small remnant stomach, or almost always. And obviously, inflammation, neoplasm, infection of the gastric or abdominal wall. So this is ideal location where you can access stomach. You don't want to go on the circle. You don't want to get on the other side, because this is relatively avascular area. Saying that, one of my partners, very, very experienced in gastrostomy placement, routinely placed gastrostomy tube from the larger curvature. And this is one of my cases when I was a fellow. He placed his gastrostomy tube from the larger curvature. It was great tube, no issues at all. The only problem is that every time we flush the tube, we get a blood bag. And when you do gastrostomy and everything is right, at the end of the gastrostomy, there is no blood supposed to come from the gastrostomy tube. If you have blood coming from the gastrostomy tube at the end of the procedure, you have a problem. So here, a little bit of blood coming, and theoretically you can say, yeah, maybe you have to wait a little bit and wait, but the problem is the patient you are with. So we decided to do arteriogram, and as you can see, obviously we swept the gastrostomy tube for guide wire, because otherwise gastrostomy will tamponade on the tract. And when we inject contrast into the gastroepiploic artery, you can see that the tube perfectly transects the gastroepiploic artery. So we embolize it. And here we actually managed to embolize from both ends, because as you can imagine, gastroepiploic artery is a kind of arch, starts from the arch that's supplied from both ends. So in order to close this bleeding, you have to embolize both doors. I don't know how we managed from the hole of the stomach to get into the other side of the artery, but we managed when we embolize both sides, and the patient is cured. Do you think my partner changed his practice? No. It was 14 years ago, and he still continued to put the gastrostomy tube through the larger curvature, and no issues at all. But, just an example. So infracolic gastrostomy was definitely described in two articles by Boston Group. From my experience, and I have maybe 5 or 6 cases over the last 10 years, every time you see this type of picture, you kind of scratch your head and say, do I really want to do infracolic gastrostomy? Then you call a few people around and say, let's talk about that. Put the patient off the table, bring the patient next day after you decide to go with infracolic gastrostomy because everybody agrees on that, and the colon drops below the stomach. So since then, that's what I do. Every time I see this type of picture, I take the patient at the table, send him to the floor or home for 2 or 3 days, bring him back, and colon drops down, and he has no issues to do just a regular gastrostomy. So this is, I highly recommend that you guys have at least 5 cases like that. You probably have to publish them. Just it's kind of interesting and probably change the patient care. But in this manuscript, this Boston group described in 6 patients this technique successfully implemented with no complications. So you have options. So generally, there are 2 types of the gastrostomy tube. One that you place from the stomach, the entry from the mouth, and the other one from the abdominal wall, transabdominal and transoral. Traditionally, IR used to do transabdominal, either couplu, catheter, pigtail, or balloon type like a knee, where GI people used to do transoral, and they call it PEC tube. The worlds collide right now. We definitely do transoral gastrostomy, and Chicago University group was very instrumental to introduce this IR-guided PEC tube, let's say. And from the other hand, because of some limitation of the PEC tube, GI doctors started to do that. And actually, they describe it many years for heart technique in their literature, but and different other names. But they also do the same transabdominal approach. There's advantages of disadvantages of each of them. So how do we do transabdominal gastrostomy? First, and you probably saw that already, you insufflate the stomach. I personally give 1 milligram of glucagon. Not everybody do that. It's not always necessary. I always do gastropexy. Usually I put 2 gastropexy anchors to prevent spillage into peritoneum. We'll talk about gastropexy a few seconds later. I personally use COP loop pigtail gastrostomy. This is original tube, but IR or radiology tube. The only difference, instead of 10 or 14 French diameter, I placed 18 French diameter. Why? Because there was a recent 7 years ago hand-published an article that showed that small diameter of the gastrostomy tube caused more complications such as occlusion. Makes sense. And since then, I switched to the large for gastrostomy tube, 8 French. It's exactly the same, like 14 French standard Mallinckrodt set, but it's called, I think it's called Deutsch. But many years ago, if you just change the size of the cut, you can attach your name to that. So this is Deutsch gastrostomy tube. So 18 French, and this works very well. And our referral people thank us for placing much bigger tubes. This is gastric anchor. There's 2 designs out there, Brown and Cope. This is a Cope, or design from the Cope place. We're supposed to have Cope gastric anchors. This is the picture from his book, as his atlas. As you can see here, it's actually our original design was the anchor is supposed to be removable. You see, there's two strings attached and one to the end, so at the end we're supposed to pull it. For some reason, it never worked. It's not the design that we use now. So, and the one more time, I'll talk about anchors a bit later. It's actually a big issue. So that's what you usually do. You inflate the stomach, you mark your target in the middle of the stomach, and then you point your needle, access needle, obviously after you give anesthesia, in the direction of the antrum, and you stick. So, and sometimes it's a bit sticky to treat. This is a picture that was taken during the gastrostomy placement at Children's Hospital of Philadelphia. Sometimes they do together with GI. GI do biopsy, and we put gastrostomy, so they save one anesthesia sedation. And a lot of these kids with this musculoskeletal dystrophy, and when I was trying to put my needle, I just couldn't penetrate the stomach because the stomach was so compliant. And we actually can see that during the gastroscopy, so I asked to take a picture. So the way to get into the stomach is make a very short and very sharp move, and that's how you penetrate the stomach. After we place anchors, we put a gastrostomy, just simple, over a wire. And then, if you use cold tubes, it's absolutely necessary to position your tube at the end of the procedure as the fundus of the stomach. Why? Because if you position in the enteral, the peristalsis will move the tube into the jejunum, and suddenly the patient will start to get feeding, stomach feeding into jejunum, and stomach food or stomach feeding is completely different than the jejunum. First, it's boluses. Second, hyperosmolarity, and that's very important because patient will come to you with severe cramps, abdominal cramps, and diarrhea. So always leave this pigtail tube in the fundus. Obviously, it's not an issue with a neck balloon tip because they just sit in the stomach, attached to the wall, and it's not an issue with peg tubes, type of tubes. So anchors generally are bad. And some people don't use it. Micro don't use it, and the Anderson don't use it. Why they bad? Because if they sit in the tissue, they can get inflamed. So my practice right now is cut the anchors 2 or 3 days after the procedure, not later than that. Because if the patient go away with anchors and you will leave them with anchors, this patient will eventually come back with infection. In the past, we had one of our attendings used to do, instead of cutting the anchors, he actually used them on the skin and leaving them there. And this is a patient that came to us 5 years after he got the gastrostomy tube placed and then subsequently removed. And suddenly he comes with a gastroenteric fistula. And when we inject it into the fistula with a Christmas tree, you can see the anchors floating in the pus. So fortunately, when you got these anchors abdominal wall and you get infected, it's very, very easy to remove because they're attached to nothing. They're floating inside the capsule, inside the pus. So you just sneak your, in my case, myocardial biopsy, and just grab them and remove the anchors. This is another example where anchors hurt the patient. This is a patient with enormous abdomen and enormous mobile abdomen. So we placed gastrostomy, everything was okay, and he went home. And a few days later, he comes with a hole, with a severe, not severe abdomen. He comes with a pus coming around his gastrostomy tube. When we get CAT scan, we see that his anchor pulled through the stomach wall, through the abdominal wall in the subcutaneous tissue. So the lesson from that, if you have a patient with enormous abdomen, try to minimize the time the anchor sits. So right now, I will cut on this patient 1 day after the procedure. So in this case, what we did, we just exchange, we obviously remove the anchor, we put a wire and put a balloon tip gastrostomy tube that occludes the entrance of from the stomach side, and the patient is cured. So transabdominal gastrostomy is great. The major advantages: lower infection rate. You don't have to track your tube through the mouth. There's always crazy bugs that sit there. It can be placed in patients with upper GI narrowing. In order to inflate the stomach, you don't have to put the Gastrojejunostomy. Oh, no. You don't have to place NG tube. It's enough to take 5 French catheter, and you can actually, using the wire, negotiate the severe narrowing and put this 5 French catheter in the stomach. More than that, if you have complete occlusion of the upper GI tract, and you cannot put your gastrostomy or NG tube to inflate the stomach, you actually can use the ultrasound fluoroscopy, put 21 gauge needle inside the stomach. If it's filled with air, you do fluoroscopy. If it's filled with water, you don't see on the fluoroscopy, you will use ultrasound. Put this needle in, inflate the stomach through this needle, and complete the gastrostomy. So this way, you guys will shine comparing to the upper GI, comparing to the GI people. This is where you can actually work with ENT doctors and tell them you can provide the service. First, you have lower infection rate. You don't care about crossing all these tumors in the upper GI tract or ENT, and you can deliver gastrostomy. The disadvantage of the transabdominal approach of pigtail, pigtail is poor anchor. It's very, very easy to yank this tube, so you have to suture them well. This is just a rationalization, some kind of anchors that are removable, and it's primarily used by GI people. In Europe, IR people use it as well. So it's a two needle, one fits the snare loop, the other one fits the wire. So you grab the, sorry, I lost my mouse. So you grab the wire inside the stomach with that and pull together. It's a great design because when you cut your suture, you leave nothing behind. You just cut your anchor, you pull the suture, and you leave nothing behind. So you actually can do even Ponsky tube through this Versa convenient method through this Versa step trocar that they primarily used for laparoscopy, but some people describe it as using for placement of the gastrostomy, even the Ponsky tube. Transoral Gastrostomy tube is an antegrade technique, but you do approximately, you start the same. You first inflate the stomach and give a glue balloon. Then you puncture the stomach, and I will show these images. So this is from Children's Hospital. We have two techniques we use here, one children's and one adult. So in Children's Hospital, because the distances are so small, I'm talking about newborns or even preterms, we usually mark the spleen, we mark the liver with ultrasound, so we see the window. Then on the table, we'll give them enema, gastric enema, and to operate the colon. Usually we put two tubes inside, one to inflate the stomach and one lasso. You will see in a second. This is also what we use it, gooseneck. So you inflate the stomach, you put your gooseneck as a target, and then you advance your needle inside this target. After you get inside this target, you feed the wire, grab the wire, do body floating, attach, put the wire from the mouth, attach the tube, and pull it through. And this is successful gastrostomy. In adult population, we do it a little bit differently. We will bend it 18-gauge needle and point it in direction of the gastroesophageal junction and try to feed the tube or wire through the gastroesophageal junction, and it's actually surprisingly works all the time. I don't know how, but it works. Then somebody will feed the wire into the mouth. Somebody will grab with a hemostat the wire. You put your tube on the wire and slide it over the wire into the stomach. Here it is. So the biggest advantages of the PEG gastrostomy tube are their bigger size. So they accumulate much less. It's much better anchoring than balloon tip or pigtail. Definitely much better. And it needs to be changed only once a year, or sometimes once in 2 years, opposite to the balloon tip, because MIG gastrostomy tube will eventually degrade. So you need to, every 3-4 months, you have to bring the patient and exchange the tube. The disadvantages of the changing of the PEG tube or transoral tube is that you have to give sedation. You guys probably saw how it's already removed. You have to pretty much rip the gastrostomy tube out of the body and put a new one. Whereas replacement of the balloon tube is pretty much painless. So another disadvantage of the transabdominal gastrostomy is very high infection rate, reduced significantly with antibiotics, and tract filling. It is well documented in the literature. If you put the gastrostomy tube, drag it through the mouth, dragging this whole gastrostomy tube through the ENT or esophageal cancers, the tract can be seeded at least 1 to 2%, and it's horrible. The patient can be absolutely cured from his original ENT cancer, but develop a huge metastasis on the abdominal wall, and I have 2 patients like that. So this is another selling point for you guys to go to ENT doc, show them the article, and explain that you can do better job. This is an example of the tract infection. Here you just give antibiotics. And this is an example of that good position, good fixation of the PEG tube is not always good. So this is what would put a good place is gastrostomy. It's a PEG type or transoral gastrostomy, and it feels great, right? But that patient 2 days later caught it, and they didn't call it, and she recovered surprisingly from this cold. And they started to treat her through a gastrostomy tube, and she died within 2 days. On the autopsy, you can see that gastrostomy tube actually migrated out of the stomach wall into a peritoneal cavity, and all this fluid here is feeding that she was food that they fed the gastrostomy tube. So even though it has very good anchoring, you have to be very careful. Gastrojejunostomy. First, I think gastrojejunostomy is better than jejunostomy. A lot of time we ask gastrojejunostomy after we already placed gastrostomy. In typical scenario, you put gastrostomy and patient aspirate, and they come to you and asking you to put gastrostomy. But let's say gastroenterology puts gastrostomy. They put a PEG tube. So can you really remove 1 or 2 week gastrostomy tube and replace it with gastrojejunostomy? Theoretically, you can, and we do it occasionally, but most of the time, it's much easier to use this barred 9-French jejunostomy tube that fits perfectly into this gastrostomy tube. Here you, usually they're very long, so you catheterize it, take your catheter, you cannulate the jejunum and put a wire and then slide this barred 9-French gastrostomy tube as a jejunal feeding tube. This is kind of unknown and indispensable device to convert gastrostomy to gastrojejunostomy. It's called gastric cannula. So you probably already witnessed the 3 hours gastrostomy to gastrojejunostomy conversion. And it's not very glamorous. So, and you can see your friends doing 6 and 40 minutes, and the fact of 2 hours trying to do gastrojejunostomy conversion, kind of embarrassing. But so to completely eliminate this frustration, the cold gastric cannula can completely remediate this frustration. And how does it work? So you took the gastric cannula, you bend it in the shape you think is most suitable, attach the syringe to the end of the gastric cannula, and then you kind of palpate your way, push your way into the duodenum. So here we see. Right now, we already inside the duodenum inject contrast. Then you feed the wire, and then you feed the gastrostomy tube or the wire. So truly, it's an incredible device. It saves your time, saves radiation, and frustration. Double wire technique. How often? The problem with conversion of the PEG tube to the gastrojejunostomy is when gastroenterologists put the tube, they usually point in that direction. So sometimes it's very difficult to make this turn. And if even when you made this turn, in advanced tube, it actually can look into the fundus, and that could be extraordinarily frustrating. So what you do, you put extra wire for support. It's very, very simple technique, saves you a significant amount of time and the same frustration. So there's some social issues with jejunostomy, and that's the reason why most of the people prefer gastrostomy. Social issue, the jejunal feet, they continuous. That means patient has to be attached most of the day to the pump, jejunal pump, where the gastrostomy feet, they are both. It's small diameter, so they can get clogged even. Some nursing homes don't accept, because of about reason, they don't accept patients with non-continuous feet. This is two gastrojejunostomy tubes, primary gastrojejunostomy tubes. One of them is shitty, and it's just single lumen, similar to the couplet, but with long extension. I actually like this tube a lot. And also carry outguide pools. I'm not sure why 3 names attached to that, but I get the 3 of them being in the same room. I prefer the first one, Shetty, to put as the primary gastrojejunostomy tube. Some people just put the primary tube, MIG gastrojejunostomy tubes, and it works. The technique is very simple. You get access, to the gastrostomy. Then you usually put a sheath, and through the sheath you using the catheters, wires, cup cannula. You're trying to cannulate the jejunum, and then put the wire and put the gastrojejunostomy tube. Here we go. This is just another example. The same thing. You put the gastrojejunostomy tube. Carry outguide cooling designed a little bit different. It's actually, I don't have a good picture, but it's designed the way that it's pointed toward the fundus. And that design eliminates the buckling of the gastrojejunostomy tube. That is quite common complication of these tubes. Unfortunately, I don't have a good picture of that. It's very hard to explain, but probably next time I'll get some picture. How does it carry outguide jejunostomy work? Lumen we use a lot of time primarily as a single, but there's some indication for double lumen, primarily when you need to drain the stomach while you're feeding. Direct jejunostomy is there are 2 types of direct jejunostomy: primary and secondary. They're completely different. So let's start with the secondary jejunostomy. Secondary jejunostomy is when patients have jejunostomy in the body. And for example, typical scenario: people have a whipple. During whipple, they put temporary jejunostomy. He's done this whipple. Then a few years later, pancreatic cancer came back. They decided not to do anything, and you have to put a jejunostomy. So in this case, it's very difficult for surgeons to put a jejunostomy tube because there's too much surgery, too many adhesions there. But because of these adhesions, it's very easy for you to put a jejunostomy tube. Why? The major problem with placing a jejunostomy tube is the mobility of intestine. You try to stick the intestine with your needle, and the intestine flies away from it. When you have intestine loop attached to the abdominal wall, that's very easy. You have a mark where you have to go, you put it there, within 10-15 minutes you're done, you are shy. For surgeon, it's very difficult. And directly over primary jejunostomy tube. For surgeon, and I used to be surgeon in the past, it's very easy to do. It's relatively easy to do. When I used to be surgeon, I did it quite a lot. You just cut the skin, pull a little suture to the skin, put the tube inside, and you're done. Right? Where for us to put primary jejunostomy tube is extraordinarily difficult because the intestine moves away. So we at Penn still do those primary. I don't. I do those. We have one physician that's primary jejunostomy tube, and I can tell you that 10–50% of patients end up in OR with perforation. So I strongly discourage people from doing jejunostomy tube unless there's a kind of unique situation that this patient absolutely cannot get surgical jejunostomy tube. Technique, one more time, very simple for secondary. You do use ultrasound or fluoroscopy and stick your needle inside the loop, and you don't even need to put the anchors most of the time, and just use the lumen advanced wire and advanced jejunostomy tube. Most of the time, you would use something like a pigtail as the primary, and then exchange it to the jejunostomy tube after a few weeks. Cecostomy. There are two types of cecostomy, two indications of cecostomy: in adults and in children. In adults, it's primarily for decompression because of the toxic megacolon, for example. We do it occasionally. The problem is that they get infected quite often. There's sometimes complications, but sometimes it works. Cecostomy in kids is completely different. A lot of kids with disease abnormalities such as spinal abnormalities, ear-stroke disease, function constipation, have a severe constipation. So if you even cannot do anyone to clean this constipation. And this is why they designed this cecostomy tube to do antegrade flushing of the colon. And Dr. Hyde, that used to be an interventional radiologist in Toronto, designed this Hyde jejunostomy, cecostomy catheter. You can see here. The idea of this cecostomy catheter is that while the patient is growing, it actually gets extended. You see this coil here? That's how it goes. So how do you do this cecostomy? First, you put your pigtail catheter. You put the anchors first, secure the cecum to the abdominal wall, put your pigtail catheter, and make sure that the tract matures. After the tract matures, 6 weeks, you bring the patient back and put this height cecostomy catheter, and a few days later, and immediately after, the patient can start using it. And usually they attach this flushing device to the cecostomy catheter and flush colon. Yeah, that's pretty much it. So, is it a good technique? I heard some criticism of cecostomy from my CHOP people, and there's other surgical technique where they attached appendix to the abdominal wall, and according to my colleagues at CHOP, it's do the cecostomy. That's probably a better technique than cecostomy for this type of situation. Thank you very much for your attention, and I will be happy to answer any questions.
Anybody have any questions? Okay, well, thank you, Dr. Itkin, for giving us your talk. I was wondering, you did mention that interventional radiologists only have 7.4% of the market share of enteric access, and you did mention that there's lower infection rates and no tract seeding with the transabdominal approaches, but do you have any other strategies as future interventional radiologists that we can use to be champions of these for interventional radiology and grab a larger market share?
ENT probably your best reference. All the time you can provide them outpatient gastrostomy service and explain them all the ins and outs of why your gastrostomy is better. You can grab this market immediately. Or radiation oncology, same. Radiation oncology and ENT. Absolutely, they will be thrilled to do it. And if you look in the literature, that's actually when we wrote together with GI doctors, every comparative study showed that IR way is much better. Why? Because they don't have aspirations that they have. during the endoscopy. We can actually, well, some of my patients I get from GI, they put gastrostomy tube because of the colon. They're afraid to go through the colon. And we are much better from that perspective. Because using fluoroscopy and amplification of the colon responses, we can see colon better, and our infection rate is less, and always know to tract A. So you definitely have a selling point. The problem in GI, docs, they own this patient, right? So if you have an aggressive GI doctor that likes to do gastrostomies, he will only tell you the cases where he can put his endoscope or high aspiration rates or all his failure. You will be successful, right? But your radiation oncology, you are the best target to expand the business. If you can create the program, that's not easy. And it will be extraordinarily attractive for them to do outpatient gastrostomy. That actually gastroenterologists always offer.
Okay, thanks.
Any questions, guys? Few words about maintenance, because when you do the gastrostomy, you merit it. There's few rules. Number one, try not to suture the gastrostomy tubes. If you can keep them unsutured, it's the best, because sutures, it's an old surgical rule. Never suture the fitting teeth. Why? Because it always gets infected. Right? Sometimes you don't have choices. You have to suture them. But try avoid that. Number one. Number two, if the patient leaking around the tube, you try to find the reason why he's leaking, and not to try to upsize it. It's okay to upsize once. Sometimes, something happens and it's stop leaking. But that's it. Because if you upsize once and patient stop leaking and 3 days later come with the patient, that means you upsize the second time, the third time, and they get 24 French tube in the stomach. And the patient will continue to leak. The only difference, you have a huge hole in the stomach. So my strategy, I'm trying to find the reason why the patient obstructed. For example, maybe it's a residual, maybe there's too much residual in the stomach. And sometimes I convert gastrostomy to gastrojejunostomy because of the residual in the stomach. And that can cure the problem. The other, so let's say you present at a stage where you have a huge hole in the stomach and it's leaking all over the place and nobody knows what to do. How do you attack that? Very, very simple. You take tube out. You admit patient to the hospital. You cover that with a Vaseline gauze, right? And check it every day. Slowly, the holes will get smaller and smaller and smaller. That takes approximately 1 or 2 days. And when the hole becomes appropriately small, you go and reinsert the, let's say, 18 or 20 gauge gastrostomy tubes. And it works very, very well. More questions, guys? Ready?
You mentioned the Cope gastric cannula, which is something I haven't seen before or used, but it does seem like it would reduce radiation in the length of procedure. How common are those used, and is there any reason that they're not more commonly seen?
I don't know. Everywhere I go, I talk about that. We just talk about it, chop in half. But we Cope lays. Yeah, Cope was here for almost 20 years. And all the people in different places use it. Yeah, but that's phenomenal device. Absolutely. You can bend it, and it looks a little bit brutal at the beginning, but then you realize that it's not. Because you really need to kind of try it and give it a few chances, because it's an incredible device.
Yeah.
Saving multiple times.
I think I could use it, for sure.
Absolutely. And you are from New York, right?
I'm actually in Temple, Texas, Central Texas. It's
Oh, I see. I see.
I think Dane is.
They're from New York, right?
Yes.
Because I think New York. Do you guys use it in New York?
I haven't seen it been used actually.
Yes. Okay.
Yeah.
No, that's a great idea.
That's a good tip.
Yeah, absolutely. When I was introduced first to that, I was very excited. Guys, more questions?
I actually have one. I just wanted to know, because I was just reading through your guidelines, and you were saying that there was, a possible kind of delayed complication of tumor seeding. I mean, what's your personal opinion about that, like using the tube?
Can you repeat? Oh, delayed complication what?
Sorry, about possible tumor seeding from the tube. Like.
Yeah, it's clearly absolutely controlled. It's too big tumor seeding. You pretty much. I have two patients. It's horrible. Patients have been cured from cancer and developed a huge metastasis on the abdominal wall with a tube eroding through this mass. It's really not fun. It can be avoided by not using transoral approach in all ENT or esophageal cancer patients.
Okay.
Okay, guys. One more time. I'll be more than happy to answer the question if you don't have. Guess. What do you think, guys? German, it should be holiday. Jeremy?
Yes. Thank you very much.
Oh,
yes,
yeah,
I don't think there's any more questions, but we really appreciate your presentation. It's definitely one of those fundamental things of IR that we can never know nothing too much about.
Yeah, I'm accidentally started giving workshops during the a few years ago, and since then I'm pretty much doing a lot of GI talking, and then but it was completely incidental because my clinical interest is different. My clinical interest is lymphatic primarily. But it was a pleasure, and please invite me next year. I'll be happy to do it again.
Thank you so much.
Thank you.
Thanks for inviting.
Bye.
Good night.
Thanks.